So everyone on the call, thank you so much for your patience. I want to introduce Dr. Sav as our presenter. He is a renowned figure in cancer research and treatment. He holds the David F. and Margaret T. Groen Professorship of Novel Therapeutics at Mayo Clinic College of Medicine and Science, chairs hematology and medical oncology at Mayo Clinic Phoenix, and leads the gastrointestinal cancer program at Mayo Clinic Cancer Center. He's also deeply involved in clinical trials and guideline development, contributing significantly to the field through his extensive research and publications in top-tier journals. Thank you, Dr. Saab, for being here and also for being patient with technology.
Well, thank you, Lourdes, and thank you everyone for being on the call. And again, apologies. I've rarely seen such challenge, but luckily we've been able to make it through. Julie, can you pull this in presentation mode, please? And I'll tell you next. So I'm going to be talking about essentially an exciting study. One of the first studies, actually the first study to look at immune therapy, and now in the setting of early stage cholangiocarcinoma or biliary tract cancer following curative resection. Next slide, please. So when we think about biliary tract cancer, as many of you may know, it's a technically a rare subgrouping of cancers. It's about 3% of all GI cancers, has a poor prognosis in the advanced setting. Thankfully, many, about 20-25% of the patients are diagnosed with early stage, and thus will be suitable for curative surgery. And I would tell you that we're seeing also, and that's a different discussion, many patients able to make it to transplant, but it's a very small percent of patients for now. So the relapse rates, unfortunately, following surgery remain high. And without adequate treatment, maybe as high as 80% for the more advanced of the early stages. And most of the times, the cancer comes back in other organs. Some can come back in the same area they originated from, but most will come back metastatic in other organs. So when we look at essentially how many cases of cholangiocarcinoma worldwide are there, there's about 140,000. So that's quite a bit. 52,000 of those are gallbladder. 43,000 are what we call extrahepatic, so outside the liver and the hepatic ducts. In the biliary ducts. And then intrahepatic, which we're seeing a rise in the United States, and these primarily would be those with that are in the ducts of the liver, ampulla of water and others. Now, when we look at the breakdown, as I said, about a quarter of the patients will have what we call resectable disease, meaning, they present early enough to go to surgery. And then about another third, so a third of the patients would have disease that's localized but not metastatic. And then about 40% will have widespread disease. Next, please. So unfortunately, the majority of patients with biliary tract cancer remain at this point of time diagnosed mostly with advanced disease. And we're starting to make a lot of strides there. But I think, we have large opportunities to continue to improve outcomes in the area of early stage cancer, where we can bring more patients into a cure than we do right now. Next slide, please. And a lot of the classes of new therapeutic agents under investigation belong now to the molecularly targeted agents and more with immune therapies. But we also are seeing more and more liver-directed therapies as well, especially in the locally advanced and the advanced stages. So quite a bit of activity, thankfully, in this disease. And I think that's actually and continues to improve our outcomes quite significantly. So pretty hopeful about where the direction of all this is going. Next slide, please. So this just summarizes at this stage, where we at with the treatment algorithm for biliary tract cancers. So we have what we call the early stage, but then the locally advanced stage, stage 3, which essentially is stage where the cancer has not spread beyond the confines of the originating area, but has essentially is impossible to remove. Now, with chemotherapy, many of these patients are finding their way to surgery. And I put a little bit of liver transplant there because more and more patients, even with intrahepatic cholangiocarcinoma, are finding their way to transplant. It's a very small percent of patients, but that's something that needs to be kept in mind. And then when we look at the more advanced disease, we have a lot of targets to go after, from HER2 to MSI high to BRAF mutations, IDH1 mutations, FGFR2 fusions, where in many of these groups, treatments have essentially produced very meaningful responses and long-lasting responses. So very exciting time. A lot of these agents ultimately will find their way into earlier stages. But right now, immunotherapy, which is primarily used in the first-line treatment of metastatic cholangiocarcinoma, is starting to make its way in clinical trials into the earlier stages. Next slide, please. So I'm going to talk briefly about the role of adjuvant therapy in early stage cholangiocarcinoma. So the role of therapy there in the earlier stages of the disease. Next slide, please. For early biliary tract cancer, surgery remains the cornerstone for a cure. So to achieve a cure, we have to be able to, for those diseases that are localized to, say, the liver or the bile ducts, that surgery actually helps with enhancing the likelihood of a cure, even with the current adjuvant systemic therapy. So when we think about surgery, it's only feasible in about a third of the cases. So about 25% clearly resectable, about 5+% that are made resectable after chemotherapy plus immune checkpoint inhibitors. But depending on the subgroup of patients, some patients actually have a risk of up to 80% to have their cancer coming back, unfortunately. When we look at the patterns of where the cancer comes back, it's mostly in distant organs, but also a good proportion of patients will have both a local recurrence, meaning, let's say, the tumor started in the liver, it tends to come back in the liver, but also tends to present at the same time, either, let's say, in the lungs or in other parts of the liver, so metastatic, so distant, in addition to the local recurrence. And frankly, whether we had what we call R0 resection, which essentially means that the cancer was cut clean without any microscopic cancer at the margins of where the surgery happened, versus R1 resections, which means some microscopic cancer was left behind, that only was discovered at the time where pathology reviewed the sample. So in both cases, we can see that the biggest issue remains that a lot of these cancers, when they come back, they tend to come back in distant organs. Next slide, please. And as a primer about why it is at this point of time important to continue to think about developing effective therapies in the adjuvant setting, adjuvant meaning treatment after surgery to enhance the likelihood of cure. So one of the first studies called BILCAP from the UK, there are a number of other studies from Asia and Europe as well, and small studies from the United States. These studies, essentially, this study looked at adjuvant capecitabine, known as Xeloda, did not, at first glance, improve overall survival and relapse-free survival. However, there was another form of analysis that was performed that who receive it improves outcome significantly over observation. And so that established a proof of concept for us that chemotherapy will improve outcome in patients with biliary tract cancer that's essentially removed by surgery. And then we look at a number of guidelines, both national and international guidelines. And essentially, the NCCN guidelines put capecitabine from the BILCAP study as the preferred with the strongest data backing it up. And then there are other options, including gemcitabine cisplatin, which, as you know, is the backbone for treatment in first line, along with immune therapies for metastatic disease. And then the ESMO guidelines, and these are the European guidelines, again, tell us that the oral capecitabine should be considered for patients with cholangiocarcinoma or gallbladder cancer following resection. They also address the question of radiation, and I'll get back to that in just a tidbit. So data supporting adjuvant radiation is actually quite limited and mostly consists of retrospective studies, meaning, experience in institutions that have been published rather than what we call prospective studies, meaning running a clinical trial prospectively to understand whether that actually improves outcome. And it does appear that there may be a role, and I say maybe because I think that's not certain, for radiation in patients who had perhaps an R1 resection, so may have had microscopic disease left out at the time of surgery. Now, the one thing I would say about that only would be applicable after a full course of chemotherapy, because as we said, most of the disease will take place, most of the disease, when it comes back outside the originating site. And so to clear the field, you have to go through the bloodstream. When the cancer cells borrow the bloodstream and the lymphatics to spread, and chemotherapy goes through the bloodstream and follows wherever the cancer goes. And so for a disease that primarily appears to distribute itself outside, say, the liver or the bile ducts, it is important to have adequate chemotherapy, what we call systemic therapy, before even consideration of any radiation. And radiation has very limited role, and as I said, we don't have enough data to support it. The Japanese guidelines, again, very similar in terms of the recommendations. Next slide, please. Next slide, please. So there was a publication in Journal of Clinical Oncology. Essentially, a group of us got together to think about, essentially establishing those guidelines through ASCO. And with that, next slide, please, presented a couple of recommendations. And these are the summary of recommendations. The first one was, is adjuvant therapy and or the radiation therapy, that's the question, important for patients who actually had resected disease that was removed surgically. And the answer was, after you look at all the data, specifically from BILCAP, so that capecitabine study from the UK, it becomes clear that Xeloda or capecitabine would form the standard of care for patients who received adjuvant chemotherapy. And so this actually is supported by a higher level of evidence. And the recommendation was that this should be used for most patients following surgery. Next slide, please. In terms of what to do with radiation, because that question comes about, specifically, as I said, in those patients with microscopically positive surgical margin resection. In other words, those patients who have microscopic cancer left at the border of the surgical specimen and the organ that was preserved. These patients may be offered radiation after a full course of chemotherapy, but we acknowledge the fact that the evidence here is very low, and that many of these patients may actually not benefit as much from this treatment. And this would be mostly considered as a possible option for patients with cholangiocarcinoma that sits outside the liver, or even gallbladder cancer. But I'd say again, the evidence is weak. This could be an option, but it is only an option after a full course of chemotherapy. And all the data that we have comes from looking back at institutional experiences, or from this one study called SWOG 0809, which was a small study that essentially suggested that this is feasible. It wasn't a controlled study, so we didn't have a control arm of chemotherapy, say, alone. So it's very difficult to say what makes sense in that setting. Next slide, please. So let's discuss a little bit why moving immune therapy into the earlier stages of the disease. Next slide, please. We know from TOPAZ-1 and from KEYNOTE study that immune therapy does have a role in patients with metastatic biliary tract cancer. So when you look at TOPAZ-1, for example, or the addition of durvalumab, which is a PD-L1 inhibitor, seems to enhance outcomes when added to gemcitabine and cisplatin versus placebo and gemcitabine cisplatin. That's both for how long a patient survives their cancer, and also how long the cancer stays under control while the patient is undergoing therapy. And so in both parameters, adding durvalumab to chemotherapy seems to improve outcome. So that establishes the first proof of principle. And now we have a second with pembrolizumab showing similar results, not the same, but similar results, that essentially tell us again that adding a checkpoint inhibitor, immune therapy, to chemotherapy improves outcomes. But interestingly, the strongest effect was seen in patients that have locally advanced disease. So this is disease that is not surgical at the time of diagnosis, but has not spread, so is not metastatic at the time of diagnosis. Next slide, please. So when we look at this slide and at the curves, we can see that essentially in that box, green box down there, is that when we look at the locally advanced disease, you can see that bar moving really in favor of immune therapy, more so than any other subgroup. Now, that's very interesting, because that tells us in the disease that hasn't spread at the time of diagnosis, that seems to be localized, that adding immune therapy to chemotherapy may provide the best benefit out of all the other subgroups of patients. And when we measure hazard ratio, meaning the longitudinal benefit from treatment, you can see that it's at 0.42, meaning that there is a 58% reduction of the risk, so no more than 50% versus 25% for the overall population. That tells you that these are the patients that do the best, and so that's exciting, because that essentially tells us that as we get closer to the earlier stages of the disease, there's a high potential that we actually will see even more benefit with immune therapy than we've seen in later stage or later phases of the disease. Next slide, please. And to enhance this further, where PD-1 seems to have a benefit, the thought is adding an agent that targets TIGIT, and we'll get back to what that means, that essentially allows a cooperative inhibition of targets that ultimately will enhance even further the benefits from immune therapy. How does that work? So PD-1 removes some of what we call the inhibitory signals, so negative signals. TIGIT in another direction also removes the negative signals while allowing essentially the positive signals that will allow that particular cell called cytotoxic T cell or CD8 plus T cell to essentially attack the cancer more effectively. So while PD-1 can do it on its own effectively, adding TIGIT, we think, makes this even more powerful. So we'll allow the cell that's responsible for killing cancer to become even more aggressive towards the cancer. So that is the promise of this agent. We'll talk a little bit about what does it mean. So Rilvegostomig essentially is what we call a bispecific agent. So what that means, it essentially has two targets that are sitting on the antibody. One is the TIGIT target and one is the PD-1 target. So this one antibody hits both PD-1 and TIGIT, allowing essentially the immune cells to be even further enhanced, stronger in attacking the cancer. And it's designed as such. Next slide, please. And when looking at in the lower box, the lower small box, if you look at essentially the Rilvegostomig, which is the one on the lowest in red, you can see that induces the strongest activity versus just combining the two agents, anti-PD-1 and anti-TIGIT, versus anti-PD-1, which is the blue line, or no treatment, which is the black line. So that agent, Rilvegostomig, appears to have significant activity in early models in the lab, essentially. And a study called Artemide-01, not to be confused with the study we're talking about, and that's in lung cancer, in patients who have seen prior immune checkpoint inhibitors, so prior PD-1 or PD-L1 inhibitors, next slide, suggested that one, it is safe and well tolerated, so that's good news, meaning that this agent doesn't appear to induce any worse toxicities than expected. But also you can start seeing elements of activity in patients who actually have seen prior PD-1, PD-L1 inhibitors. Remember, this is a bispecific agent that essentially, so an agent that targets both PD-1 and TIGIT. And so it's good to see some responses and some very prolonged, what we call stable disease with some shrinkage in patients who have seen PD-1 inhibitors prior. So that essentially is a good first proof of principle. Next slide, please. So that takes us essentially to the study that we want to present. And this is a study that's now ongoing. Not yet in the United States, hopefully soon enough in the US, ongoing in lots of parts of the world already. This is a study that, next slide, please, that is looking at patients with cholangiocarcinoma, early stage biliary tract cancer that essentially have been resected, so have been removed surgically, and essentially are eligible for what we call adjuvant therapy, right? I mean, these are the patients that we've been discussing. These are the patients who essentially are presenting with early stage of the disease. Their cancer gets removed, and then we plan to give them treatment after surgery, chemotherapy. And so this applies to all biliary tract cancer, whether it's intrahepatic cholangiocarcinoma, extrahepatic cholangiocarcinoma, or gallbladder cancer. So all the cholangiocarcinoma family of cancers. And this will allow both R0, mind you, R0, again, to remind you, this is when you actually get a very clean cut with a safe margin. And R1 resection is when, unfortunately, the margin continues to have some microscopic cancer there. And the patients are allowed to enroll on the study up to 3 months after their surgery. Essentially, for many reasons, we do want to have the tumor sample available when possible from the resection, because that helps us also understand a little bit more what is going on with the immune components in the cancer, and hopefully help us also in the future understand who are those patients who do the best from this treatment. And the patients, about 750 of them, will be randomized to rilvegostomig and chemotherapy versus placebo plus chemotherapy. So everyone gets standard chemotherapy, and about half of the patients, with a flip of a coin, will be randomized to adding rilvegostomig. And the primary endpoint is the time it takes for the cancer to come back, hoping that we'll see less and less patients having their cancer coming back. And we also look at survival and progression-free survival. Now, for the chemotherapy, it's a choice of the investigator. So I tell you personally, I individualize the decision behind what is the one choice versus another. So in this instance, most patients will get capecitabine. However, selectively, I've given gemcitabine, cisplatin for some patients, especially those that I thought are at higher risk. And again, data is emerging. Most of the data is with capecitabine, but we have some data here and there, specifically from Asia, that suggest, perhaps some benefit for some groups of patients. And then because this is an international study, there's an agent that's an oral fluoropyrimidine, so a sister drug to capecitabine, approved in Japan, that will be allowed, again, backed by data from Japan. Next slide, please. So not to belabor over this, we've talked about the inclusion criteria, and then the exclusion is, of course, if a disease was not taken out by surgery, because that's the intent of the study, is to show that treatment benefits those, hopefully. Again, we don't know, because that's why we're running the study, but hopefully will benefit patients in addition to chemotherapy versus chemotherapy alone. Next slide, please. So what does the study entail? So we'll give chemotherapy as per standard. That's on the right box. Usually give it for 6 months per standard of practice. So either capecitabine or S1. S1, of course, is not available in the US, but capecitabine is, and is part of our standard. That's an oral drug, or gemcitabine, cisplatin, 2 IV drugs that would be given for close to 6 months. And then added to that would be essentially either the immune therapy or the experimental agent rilvegostomig, with dosing every 3 weeks IV. So that's given intravenously every 3 weeks. And the duration is 12 months. So even after you stop the chemotherapy, patients will continue for another 6 months with the immune therapy or the placebo in that sense. Next slide, please. So this just puts it in a different way, just to make it a little bit more clear. So the combination phase is around 6 months, where you give rilvegostomig with a placebo, or placebo with chemotherapy every 3 weeks IV, and then chemotherapy, depending on whether it's oral, such as capecitabine, or IV, such as gemcitabine, cisplatin. And then the next 6 months will be the monotherapy phase. So depending on which one the patient was randomized to, it'll be the rilvegostomig or placebo. Now, it is important to understand that both the physician and the patient will be blinded to what they're receiving, and the sponsor. So everyone, everyone that's involved in the study at the level of design or at the level of participation or patient will not necessarily know which agent, whether they're getting the rilvegostomig or not. They'll know they're getting the chemotherapy because that's standard of care, but we remain blinded to this. And that's important, because for these types of studies, if we know, then we introduce a significant bias, and we certainly compromise the study and any hope to bring this agent ultimately to the clinic. That's how these studies are designed. Next slide, please. So participant on the study is expected to continue in the study after the last dose to evaluate relapse-free survival. So after the whole year of treatment, then we continue to observe patients, we do scans and others, so we can capture how many patients are cured from their cancer. And hoping that with the addition of the immune therapy agent, we were going to increase the likelihood of surviving the cancer significantly versus essentially those patients who may not have received the immune therapy, but still benefit from the chemotherapy as per standard. Next slide, please. So these are the countries that will be participating into the study. So we got the Americas, that includes Canada, the US, and Brazil. So then Europe, parts of Europe, and parts of Asia Pacific, that includes China, India, Japan, and Australia, and others. In the United States right now, we don't have site. Mayo Clinic and other sites will be some of the first sites to open the study and make it available to our patients. Next slide, please. All right, so I'll stop here and take any questions, and I think we can go into question mode.
Yes, we have some questions that have come in already.
Please.
If anyone else has any questions, please put them into the Q&A or the chat. And again, please remember to make them general in nature. Why is it that in a phase 3 trial requires half the group to only receive the standard of care when the standard of care is so readily documented with data and results from across country and the world?
Yeah, no, thank you for this question. So everyone gets standard of care in a phase 3 study. Every single patient will get the standard of care. Only half of the patients will receive the experimental agent. In this case, in addition to the standard of care, a half will receive Rilvegostomig, and the other half will receive a placebo form of the agent. But every single patient will get the standard of care. So no patient would be deprived of the opportunity to receive the best documented standard to help with their disease after surgery.
If a patient is interested and eligible, what would the next step be?
Yeah, so at this point of time in the US, the study is not available. I don't believe, unless Julie corrects me on this one. But many sites, including our Mayo Clinic site, will have this available. It will be essentially on the available through cancer.gov. I'm sure through Cholangiocarcinoma Foundation can help also navigate a lot of patients to the closest site that has the study, but also be able to contact the sites. Every site will have their contact information available through ct.gov, but also I would assume through direction from Cholangio Foundation to get essentially to this study.
Okay. If a patient is R0, how would this be useful since presumably there are not local tumor cells present to be affected?
Yeah, unfortunately, when we say R0 resection, that means when the surgeon goes in, cuts the tumor, the pathologist assesses the boundaries of the tumor and sets it clear. That does not mean that cancer cells have not escaped and are hiding in other organs. And so even in the presence of an R0 resection, although the cure rate is a little bit higher than, say, an R1 resection, most patients, unfortunately, will have their cancer show back up somewhere in other parts of the liver, say, or in the lungs, bones, lymph nodes. So having an R0 resection does not remove the risk of the cancer coming back. And as I said, it remains at a high rate, even in patients with an R0 resection. That's why we recommend chemotherapy today. So outside of a clinical trial, we recommend chemotherapy, either capecitabine for some select patients, perhaps gemcitabine, cisplatin, for patients with cancer that has been removed, regardless of R0 or R1.
Okay. Is rilvegostomig being used in recurrent situations versus as a first-line adjuvant?
So in biliary cancer, it's not used. Or in any cancer at this point of time, it remains investigational. It's showing a lot of promising signs in lung cancer, which is a cancer that is known to respond well to immune therapies. And one of the exciting things about bringing it to cholangiocarcinoma, to biliary tract cancer, is we know that in biliary tract cancer, immune therapy added to chemotherapy has improved outcomes significantly and enhanced the likelihood of living longer and of the cancer staying under control longer. And we've seen those mostly beneficial in what we call the locally advanced disease. But in all disease, even the metastatic disease, the addition of immune therapy has played a role. And that makes it even more exciting to bring an agent like rilvegostomig into the mix. So today, outside of a clinical trial, this agent is not available for patients with cancer, specifically for biliary tract cancer.
Someone is asking if they can participate if they're 12 months after resection and still NED. I think you said, was it 3 months, the cutoff?
3 months. Yeah, 3 months is the cutoff. And that's not a random point. That's based on a number of studies that have looked prospectively at the value of chemotherapy following surgery. And it seems that after 3 months, there is significant loss of benefit from giving treatment. And so one can argue that the potential harmful effect from treatment weigh off any potential benefits. And as such, it is not recommended to give adjuvant treatment after the 3 month following surgery.
If someone's on pembro, durva, would changing to rilvegostomig be an option?
So I'm assuming that's a question for a patient with more advanced disease. And so the short answer right now, we don't know. This would need to be explored eventually. There are some studies that will explore the role of rilvegostomig in patients who otherwise would get PD-1 inhibitors. Now, we've seen in lung cancer, at least in the studies, that rilvegostomig may work for some patients when drugs like pembrolizumab or durvalumab stop working. But in this particular setting where we're studying the value of this agent, so rilvegostomig added to chemotherapy, it is limited to patients who have had surgery and have not seen any other treatment at this point.
If a patient is eligible but has a targetable mutation, would this still be a recommended study for them to take part in?
Excellent question. I like this question. The answer is unfortunately not. Unfortunately, no targeted therapies have found to show any benefit in the earlier stages of the disease. And so at this point of time, this would be a study that any patient, regardless of whether they have a targetable mutation or not, or fusion or amplification, so any alteration, genetic alteration, would not prohibit them from going on this study. My hope is that in the future, in the near future, we'll also start having more of the agents that we've shown are active in the more advanced disease, such as the FGFR2 fusion group, such as the HER2 amplified group, or the IDH1 mutations, that we start looking at those agents in earlier forms of stages of the disease. Today, that has not been done yet, and that has not proven to be of any benefit to patients. So for all patients, regardless of their mutation or fusion or what have you, those patients would be considered eligible for this particular study that we just discussed, so the Artemide study.
Okay. For those patients who do poorly in a trial where they have been enrolled in the inactive arm, will they be moved into the active arm? So is there crossover?
Well, that's a good question. Well, that's assuming that going to improve outcome. We hope it does, but we don't know that. That's why we're doing the study. And so everyone is getting active treatment in both arms. Chemotherapy is active. It's not as active as we'd like it to be. That's why we're trying to enhance its activity with Rilvegostomig. But today, the way the study is designed, the patients will have one arm or the other, and that's the arm they stay on. There's no, for now at least, things may change in the future, but for now, the way the study is designed is, patients will get on one arm or the other, and that's what they stay on.
What kind of side effects are likely with rilvegostomig?
Yes, no, that's a very, very good question. So the side effects are actually pretty predictable in the sense that they're not very different from what we expect for what we call immune-related toxicities. And so most of the toxicities are essentially related to the infusion itself. Very, very few. It's an antibody, and so we can get some what we call infusion reaction that are acute that are in the unit. And we can see essentially toxicities that relate to what we call immune-related events, meaning anytime you're going to make the immune system more powerful, there's at the site of the tumor, there's a chance that the immune system becomes too strong to the point where it starts attacking some of the normal organs. That's a rare occurrence, at least in its most severe form. But we see that with pembrolizumab, we see that with durvalumab, and we see it here as well. And that essentially, is a toxicity that in today's world, because we have become quite accustomed to these types of agents being used in clinic, they're mostly relatively manageable in the world we live in today.
Okay. I know that we're at 3 o'clock and I want to be respectful of your time. So if anyone has any other questions, or if we have questions here that we haven't answered, we'll make sure to send those answers out to you all so that you get those responses. Thank you, Dr. Saab, for your time and for answering all of these questions for us.
No, it's my pleasure. And again, apologies about the snafu at the beginning, but hopefully we made up for some time and were able to take quite a few questions. And it's always a pleasure to be with you and with everyone on the call. Thank you.
Thank you. Thank you, everyone.
All right, take care. Bye-bye now.